Hello, everyone. Welcome to the Conversation Project Community Call, and thank you for joining us today. I hope that you all are having a great week so far. My name is Naomi Fedna. I'm the project coordinator on the Conversation Project, and today I'll be your Webex host. So while we're waiting for people to join us, I'd like to run through a few Webex tips and tricks. So if you have any questions or comments during any point in time during the call, feel free to type it into the chat box at the bottom of your screen and send it to all participants. And you can also use the raise your hand icon, which is located on the right-hand side, and we'll be able to call on you to voice your question or comment. And if you're having any technical difficulties, please hit the same drop-down menu where you can click all participants and click chat to host, and I'll be able to help you out directly. And so to just get things started in the chat, answer this question that's on your screen. What type of organization or institution are you affiliated with? Are you with a hospital, a different type of healthcare organization, a grassroots community organization? How did you hear? So what type of organization are you affiliated with? You can just type that right into the chat. So we have some folks who are part of community hospitals, Rasmussen College in Florida, a municipality, nursing student. Great. Awesome. All right, and so before we dive right in, we want to know where people are joining us from. So to get a sense of where you're located, please, to get a sense of where you're located, please point to where we're calling from on the map. So I'm going to put my arrow here right on Massachusetts. I'm calling in from Boston. And for you to do this, use the arrow key in the upper left-hand corner of your screen, right above the Webex presentation you're currently viewing, and click the arrow key and then click on the map where you're located. So we have someone in Georgia, South Carolina. Great, it looks like we have a great group with us today. A lot of East Coast folks. All right, and so today, Patty Webster will be leading us in the call. I'm going to hand the ball right over to Patty, and you can take it away.
Great, thanks Naomi, and good afternoon everybody. And it's just 12 o'clock in Santa Barbara, and I do see we have one person from the West Coast. So Jean, thanks for representing California. I am excited that you all are here, and we have a great agenda for everybody today. My name is Patty Webster, and I work with Naomi, and I co-lead our community engagement and learning for the Conversation Project. I see some familiar names here. Really excited to see folks joining from all different types of organizations. So we hope we're going to give a little bit to everybody today. So I'm just going to do a quick overview of our agenda. So today what we're going to do is we're going to dive really into a presentation that we're really excited to share about the Conversation Ready work that's focused a lot on the healthcare side of things. Before we do that, I'm going to just run through some updates and new resources that we're excited to share from the Conversation Project. And then I'll do a little bit of framing and why this call and why this topic today. And then we'll dive into a presentation by my colleague, Kelly Mccutcheon Adams, about Conversation Ready. We'll leave some time for questions and discussion and then do a little bit of wrap up and some resources to leave you with. Before we do that, for those that haven't joined our calls before, I want to just let you know that we are really informal. We want to make sure that people have opportunity to share ideas, ask any question that you want during the call. And so, as Naomi mentioned, just feel free to heavily use that chat function down on the bottom right. Anytime you have a question or idea, feel free to jump in, and I'll just check in here and there and make sure we give people an opportunity to share. So just real quick, this is our regular community call. So we host these every third Wednesday of the month. Just coming up to share a couple of topics so you can put these on your radar and on your calendar. The next call is May 15th. We're really excited about this call as well. We're going to hear from a couple of our community members on how they have started working together and organizing and building coalitions within their own communities and within their states. We'll have a mix of grassroots to statewide and cross-state coalitions that are going to share. So hopefully you'll have a chance to join us in that call. We have our Community 101 call in June, and that is our call that introduces you to the Conversation Project, what we're all about, and walks you through the guide that we have on getting started in your community. So if you want that type of information, please join us in June. And then July, we have our Community 201 call. So for those who are a little bit more seasoned like today, we have some really exciting presentation from the Massachusetts Coalition for Serious Illness. They're going to come and share messaging from a campaign and research that they've been doing around messaging for end of life. So really excited to have that lined up for the next couple months. Some new resources that we have. If you have received our newsletter, you may have already seen this. If you don't receive our newsletter, I encourage you to jump on and join and sign up for these newsletters. We share resources, stories, and events that are happening across the country. We have a new video from our own Ellen Goodman, who basically pulls together all the data in a fun, short snippet about why these conversations matter and what we learned through our national survey. So I encourage you to check out that video, and you can feel free to use that within your own communities. If you've got folks who both love stories and data, you can use this along with stories in your own presentations. The next resource that I'm really excited to have, this is based on feedback we heard from folks like you on calls and from communities we work with, that we wanted to make sure that this is available widely. So we translated our standard slide deck. So we have a slide deck that accompanies our Conversation Starter Kit. It's a workshop slide deck that you can use to create your own workshops. You can take that deck and turn it into your own. We've translated that into Spanish. We also have an end of event evaluation that you can use that's now in Spanish, and you can find both of those here on our website. So I just included the link there. And I just want to give a shout out. We had our own internal IHI Latin America team start and work on those translations. And we had one of our community members, Nora Luna, who's the Director of Diversity at the Nathan Adelson Hospice out in Las Vegas. Nora and her media team edited and revised, and we were just really excited to have a joint collaboration on this, so thank you so much to their team. And thank you, Naomi, is popping the resources in the chat button so you have easy access. And then finally, on our website, we just added a new top tools page. So I know this is tiny, but this is the home. If you look on the top bar of our website, here on the tab, here is a top tools page. If you click on there, it just lists some of our tools that we've heard from the field are really kind of the go-to resources. We put that all in one page so you can easily get there and start using some of those tools yourself. And then I know folks have seen this. If you haven't yet had a chance to see this on our website, and I have the link here on our Get Involved page, we have our Conversation Champions map. We have had a lot of people inputting their pins, and we encourage anyone who is using TCP or influenced by TCP to add your pin. You are champions. You are spreading this within your communities. We often refer folks to these maps because there's some really great resources, and people are sharing a little bit about what they're doing, how they're doing it. If you click on these pins, you can read a little bit about what folks are doing. I encourage you to check it out because you can use this to network, and we often point people here and loop people together. So hopefully you'll join that Conversation Champions map. And then one last reminder before we dig into our topic today. We have what we call our Community Activity Survey. We host and send out a quarterly survey to all of our community members who are using TCP resources or are influenced by the Conversation Project in some shape or form. This is our way to track impact and see all the good work that you're doing. That survey is now open, and it will be open until Friday the 26th. So I really hope that those of you who haven't yet had a chance to fill that out can go to this link here and fill out that survey. We try to keep it short and sweet, and we have some questions there, even if you haven't hosted any activities this quarter. So this would be January, February, and March. We have some questions on there, just 1 or 2 open-ended questions that we'd love to get your ideas on. So I encourage you to fill that out. We know that today is the day after National Healthcare Decisions Day, and so I just want to shout out to all of you who have been working really hard across the year, and especially yesterday and this week. We know there's been a ton of events in honor of National Healthcare Decisions Day across the U.S., and just want to thank everybody for being involved in that. There's an incredible amount of traction that I've seen on Twitter and Facebook, so if you haven't, check it out. There's a lot of really good resources out there that people have been sharing in honor of National Healthcare Decisions Day. Okay, I'm going to just check chat. Naomi, thanks for putting in the links. If anybody has any comments or thoughts, go ahead and pop it in there as we go. And so what I'm going to do is provide a little bit of framing of this call and kind of why this topic. So we know that National Healthcare Decisions Day is really all about prompting and jump-starting conversations and getting people to think about advanced care planning. And so as the Conversation Project, you know, and those that don't yet know, we are a public engagement campaign that's dedicated to assuring that everyone's wishes for end-of-life care are expressed and respected. We often focus our community calls on the expressed side of things and really focus on what can you do within the community to get those conversations happening early and often. And we have our other piece that we're really going to focus on today is that respect part. Once those conversations are happening, once we know the wishes of our loved ones, we want to make sure that they are respected when the time comes. And so we do this and we think about the conversation on a continuum. And this is a great tool that the Cambia Foundation, one of our founding funders, put together. I love this. It basically talks about end of life across a continuum and having conversations at 3 different points in your lifespan. Oftentimes conversations are happening here at the end of life. We're trying to move this upstream and make sure that conversations are happening at age 18 when people are healthy. Again, if there is a chronic illness diagnosis, conversations are happening then, and then those wishes are respected at end of life. So this is what we call the continuum. We focus a lot on the express part in the comfort of our own home, making sure that conversations are happening before a crisis arises. And once they need to be respected, those wishes that hopefully have been documented are then accessed and implemented, and that's kind of this respect side. And so as the Conversation Project, our approach is what we call this double helix approach. And we really focus on not just what's the matter with me. We want to make sure we are talking about what matters to me. And really our whole work on both spectrums is really focused on value-based conversations. So taking the clinical out of it and really getting down to the core of what really do you value, what matters to you, what does quality of life look like to you. And so we focus a lot of our efforts and these community calls on this public awareness and community engagement piece. And we know that we cannot do it alone with just the community. We need to then work together with health systems to transform the system to ensure that those wishes are respected. And so that's why we're here today and what the next steps are, especially after Healthcare Decisions Day. We know we focused on expressing those wishes. How can we respect those wishes? And so we're really excited to have our guest speaker here, who is our dear esteemed colleague, Kelly Mccutcheon, who's going to share a little bit about updates on what they've been doing to respect those wishes. Kelly is a medical social worker. She has a phenomenal background. She's worked in emergency departments, nursing homes, ICU, hospice settings. She leads our Conversation Ready work with a team of really highly valued players from a lot of different organizations that have been testing out some principles she's going to share with you today. She has been focusing her career on critical care and end of life. She teaches the IHI Breakthrough Series College, and she is a woman of many hats. And I will go ahead and pass it over. Make sure we've got Kelly with us.
You do, Patty. I'm here.
Super. All right. So, Kelly, I'm going to go ahead and pass the ball to you, and she's going to take it away and share Conversation Ready with us.
Great. Thank you, Patty, and I appreciate that kind introduction. I have to warn you all, this is hour 5 of teaching on webinars for me today, so if I start glitching, Patty and Naomi, you might just need to unplug me and plug me back in because it's been quite a day.
But we told people we were really casual on this call. And so
okay,
we'll
good. That's good. I'm getting a little punchy at this point. So, but I'm really delighted for this opportunity to be here with you today. Patty mentioned my professional background, which certainly helps me be very passionate about this topic because the bulk of the work I've done in my clinical social work career is related to end-of-life care issues. But I'm getting increasingly passionate about these topics because of my age. I'm in my late 40s, and my husband and I are only children, and between us, we used to have 9, now we have 8 parents, step-parents, former step-parents. We have a complex family system, so only children now with 8 aging parents, in-laws, et cetera. So these topics are certainly top of mind for me as we watch our own little silver tsunami come towards us as a family. But I'm also noticing that my friends were in that sandwich generation. Many of us had kids at an older age, but we've got aging parents as well. And these topics are just very fresh, and people are living these issues each day. Patty, you mentioned sort of age 18, and I had to just share a quick story because I think it speaks to what can happen when we normalize these topics. My husband and I have a 9-year-old and a 12-year-old, and we live in a village in Vermont. I telecommute to IHI in Boston, and we have a funeral home in our neighborhood. And we were driving by one day, and every little side street was packed with cars. Every little side street just packed with cars. And my kids said, "Oh my goodness, like who do you think died that there would be this many cars?" And I said, "Well, maybe it was someone who was, younger than you would expect." So it only took me 2 seconds on Google using the name of the funeral home to figure out who had died, and I shared that information with my kids. A couple days later, we're driving by the same funeral home. No funeral going on, and my 9-year-old looks at my 12-year-old and he says, "Tess, do you have any end-of-life care wishes?" And she puts on her, full tweeny self, and it was like, "No, do you?" And he's like, "Well, I would like my ashes to be scattered in nature." And meanwhile, I almost drove off the road, just not words I thought I'd hear coming out of my 9-year-old's mouth. And I thought to myself, please let me be dead for decades before that information is needed. But it was such a reminder to me of what happens when we normalize these conversations. My kids hear me talking about this all the time. Since I telecommute, they come home. One of them's going to come home soon while I'm, on the phone. And I think we have such an important role to play in communities, as you all are doing, and in healthcare and how we normalize all of this. So to get started, and this particular quotation uses the word physician, but I want you to also think about this could be nurse, this could be chaplain, this could be social worker, so this expand out here. This is from Oliver Sacks. Being a physician involves much more than handing out diagnoses and treatment. It involves playing a role in some of the most intimate decisions of a patient's life. This requires a considerable amount of human delicacy and judgment. And I just love that quotation because I think that's really the beating heart of what this work is. Patty mentioned that the Conversation Ready work is, I like to think of it as the Conversation Project is like the big circle, and then Conversation Ready is a smaller circle within that big circle, just like the faith community work is, and the community work, and the employer work, and the public engagement. There's lots of different aspects of this work. So the Conversation Project got started back in 2012. I was actually, strangely enough, the original director of that work. And then I had the opportunity to lead the healthcare aspect of it. Someone far smarter than I at IHI said, gosh, if we're going to go out there and activate the public, we should probably be ready to receive them. And that's where the phrase Conversation Ready came from. So when I say Conversation Ready, I'm referring to what do healthcare systems need to do to be ready to receive, record, and respect people's end-of-life care wishes. We did that with 10 pioneer sponsors, dear friends of IHI, who came to the table when this was just a twinkle in our eye. We led a collaborative in 2014, ran a seminar, wrote a white paper. We've had 2 more collaboratives, one in Howard County, Maryland, and one in Massachusetts. And we just published our newest Conversation Ready white paper. It is not a revision. We decided we had learned so much between 2015 and 2019 that we were just going to start from scratch. So that's what we did. We wrote a brand new white paper that came out in March. I'm sure Naomi has kindly shared it hither and yon. And very soon, we will have our Conversation Ready toolkit out in the world for free, sponsored by the Gordon and Betty Moore Foundation. The toolkit is a persona-based teaching tool. What do I mean by that? I mean that we created 4 different patient stories. They're amalgamations of stories that we and our faculty have lived through with patients. 4 different disease states and progressions, 4 different family constellations, 4 different cultural backgrounds, and we're using those personas as a backdrop for teaching about the Conversation Ready work. No matter how much we know that these issues are systemic and that we have to approach them systemically, we still hear from providers time and time again, but I just don't know how to start the conversation. So our hope is that the white paper together with the toolkit are like twin pillars that help hold the system up. So one is very focused on the systemic issues and the things that need to change systemically within healthcare, and the other is very practical information for clinicians about how to start these conversations. So I can't wait. I'm so excited. I'm going on vacation next week, and right when I get back from vacation, that should be out in the world. So looking forward to sharing that with you. And I want to say my time today is just to give you that high-level overview. If you're interested, those 2 pieces together would give you a much deeper dive. I don't think it'll surprise you to know that more than 9 in 10 Americans think it's important to talk about their loved ones and their own wishes for end-of-life care. And nationally, but there's a gap, nationally 32% have discussed what they want when it comes to their end-of-life care with their loved ones. Our colleague Lachlan Farrow at Beth Israel Deaconess always says, it's always too soon until it's too late. And I can tell you, as my husband and I navigate these issues with our parents, we're definitely encountering some of that. Nobody wants to think that the rainy day is coming. In one state, 13% had had a conversation with their healthcare provider about end-of-life care wishes, and only 27% of patients with a serious health condition had a conversation with a healthcare provider about their end-of-life care wishes. So even in the face of a serious health condition, we're still seeing just roughly over a quarter. So there is a gap, and the citations for this information are in the lower left-hand corner. That gap matters to patients and family because goal discordant care, so when there's not an alignment between what mattered most to people and the care that they received, goal discordant care can cause harm. Sometimes literally, physically, it can expose patients to the risks of treatments they don't want. So getting intubated when you didn't want to be intubated, getting a feeding tube if you didn't want a feeding tube, if that's not consonant with your wishes. It can cause patients and their families to lose opportunities to have spent their time differently, perhaps to have received an intervention that required a higher level of sedation, and then losing that opportunity of consciousness. This can foster distrust of the involved health professionals and the organization if and when patients or their families realize that there was a better alternative. It may make them less willing to return or to recommend that healthcare organization, and at worst, there can be an undignified death. And I don't mean undignified like, oh, that behavior was so undignified. I mean lacking dignity, like the truest sense of the word undignified, lacking the dignity that that person was owed. So we know this gap is important. And something that we've really been thinking about more lately is the way that the pendulum swings societally, sometimes case by case, but sort of overall in society, that there's this pendulum of decision making. So if we think about this dot over here on the left, representing the pendulum being swung in that direction, We can think of historical systems of very paternalistic care where the clinicians decide without patient input. I'll do whatever you say, doctor, you know best. It wasn't that long ago that doctors and husbands would choose not to tell a woman that she had breast cancer. Like, that's not ancient history at all. So that's one extreme, and I think we had a reaction to that extreme, and we swung way over to the right, which is the patient decides without clinician input. The downside of this is that it sort of presupposes that the patient has been to medical school, that the patient would know whether a time-limited trial of a ventilator might make sense given their wishes, whether having a feeding tube would or would not align with what matters most to them. So when we swung that pendulum way over to the right and clinicians were more in a space of neutrality, well, you could do this or you could do this. I'm just here to respect what you wish. We were losing so much of clinician expertise in terms of the relationship between a particular treatment and what matters most to people. So in the conversation-ready work, we're trying to bring that pendulum back towards the middle, which is the clinicians have expertise in the medical pieces. The patient has expertise in their own values. And if you can bring together the patient values with the medical expertise, you can start to work your way, not perfectly, but you can start to work your way towards a goal concordant plan of care. Maybe that involves hospice, maybe that involves being in the hospital, maybe that involves getting to pet your cat, maybe that involves taking an ambulance ride by the ocean on the way back to your home. There's lots of different layers and levels at which this can happen. But we don't want to absent the patient voice, and we don't want to absent the clinician voice. We need them to be working together if we're going to get to the right place. So over these last 6+ years, coming up on 7 years, that we have been trying to crack the nut on what it means to be conversation ready, we have evolved towards a system where there are 5 conversation-ready principles: exemplify, connect, engage, and steward. And those 4 together create respect, meaning goal concordant care, that people are cared for in the way that they would wish. We used to treat these, they used to be in a different order. I will spare you all the details of why it changed, but we used to treat these as 5 distinct things, and we really came to understand that it was the first 4 that created the 5th. So we now visualize this differently. And there's an important relationship between exemplify and connect, and there's an important relationship between engage and steward, which I will mention as I go along in these. I know I'm moving kind of swiftly. Just a reminder, these are gone into much greater depth in the white paper, and then once the toolkit is out, you will have 4 case studies that are like, Mr. Lynch has this situation. How can we start to talk with him? So you'll get to see in the toolkit really concrete ideas of what this looks like. So what are these conversation-ready principles? I'm going to give you the high-level overview and then take you deeper on each one. And please stop anytime, stop me anytime, chat to all participants if you have any questions, comments, something that needs clarification. I love to stop and answer or, hear from you, so please don't hesitate. So the first is to exemplify this work in our own lives, so that we fully understand the benefits and challenges. The second is to connect with patients and families in a culturally and individually respectful manner. The third is to engage with our patients and families to understand what matters most to them at the end of life. And the fourth is to steward this information as reliably as we do allergy information. Again, it's those 4 combined that create the 5th. Respect people's wishes for care at the end of life by partnering to develop a patient-centered plan of care. I will go into these more deeply just by way of explanation. These 4 are the main areas of systemic work that we have come to learn that a healthcare organization needs to undertake So if an organization wants to become conversation ready, they have work to do around how they're going to exemplify this work in their own life as clinicians. There's work to do around how they're going to be culturally humble. There's work to do around how they're going to proactively engage. There's work to do about how they're going to reliably steward this information. So these principles become a roadmap of the work that needs to be done. We're going to go a little deeper here. So when we talk about exemplifying this work in our own lives, we're referring to walking the walk. The reason that people wear "I voted" stickers or "Be nice to me, I gave blood today" stickers is because we're trying to inspire other people to do the same thing. So, hey, I'm proud, I voted. You know what? It's still election day. I'm hoping you're going to stop at the polls on the way home. Hey, you know what? Down the hall, we're having a blood drive. I just gave blood. I'm hoping you'll consider doing that on your lunch break. That's the same way of thinking around doing this work in our own lives. What do I mean by that? I mean, have we had the conversations with our loved ones? Can we look at the people that we serve and say, you know what, I did this, there were some bumps, but it was totally worth it. And I will tell you, back in 2012, when this work was getting off the ground, I procrastinated the heck out of this. I'm not going to lie. But spring, summer 2013, I already mentioned I'm an only child. My mom is a single woman. I'm it when it comes to healthcare proxy stuff. And we kept punting. We kept moving it down the field. And finally, I realized, and the Conversation Starter Kit really helped me realize this, we hadn't made a concrete enough plan. We just kept saying, oh, we'll talk about it the next time you're here. We'll talk about it the next time you're here. And we kept not doing it. So she was headed up for Easter. It was right around this time of year, 6 years ago now. And I was like, Mom, I really want us to have this conversation, but it seems like we keep putting it off. Can we think about what might be going on? And she said, well, I really don't want to cry in front of your kids who were, 6 and 3 at the time. She's like, I know I'm going to cry and I don't want to cry in front of your kids. And I was like, okay, do you want to go to a coffee shop? And she was like, I don't really want to cry there either. I was like, okay. So we ended up in a park. We sat on a bench in a park, and she wasn't kidding. She cried the entire time for an hour. And that's my mom, and that was highly predictable. And she had a lot of sadness and pain about her own mother's death from Alzheimer's, which occurred when my first daughter turned 1 month old. So there's just a lot of water under that bridge, and it was an emotional conversation, but I feel very clear on what's important to her and what matters to her. And then later that same summer, I had a conversation with my dad. He's a retired spine surgeon, orthopedic spine surgeon. He's a very practical guy. He is married to his third wife, and there's some complications there in terms of sort of like my relationship with her, who will step up to, make sure his wishes are honored. So my mom, single woman, totally different set of issues. So my dad and I sat down, and I'll never forget it. He said, Kelly, I believe in the strength of the tribe. And when my medical needs are draining from our tribe, and we're not Native American, he doesn't mean that, he means family tribe. He said, when my medical needs are draining away from this family, either financially or emotionally, I am done. I don't want more at that point. So 2 very different conversations, but both help me give clarity, help me have clarity. So now when I teach about this, I have greater confidence in being like, I know I haven't procrastinated it. My husband and I have had these conversations. I actually, January 4th of this year, I fell on ice and hit my head very hard and went into amnesia for 5 hours. I was just on a crazy little loop, and my husband really wondered, like, is this it? And he was calling up in his mind the things I had told him mattered to me, like, I want to be able to intellectually and emotionally parent our children. Now, thankfully, I came out of the amnesia. It's been not my best winter ever. But coming out of it and realizing how much more serious it could have been, I was really glad that my husband and I had those conversations. So both in declaring my own wishes and in talking with my parents and talking with my husband, I'm better able to exemplify. This can be done systemically, like it is at Beth Israel Deaconess, where they have Talk Turkey Day. And they do this right before Thanksgiving to encourage their staff and their physicians to go home at Thanksgiving and talk turkey. They give out tools. They chose Thanksgiving because Beth Israel Deaconess is a merger of the oldest Jewish hospital in Boston with the oldest Catholic hospital in Boston, and Thanksgiving is not a religious holiday. So it's something that they could come together and be promoting for staff. They also do National Healthcare Decisions Day events, so that's an example. At Erie County Medical Center in Buffalo, New York, they have a palliative care doctor on their outreach team who's been a big asset to their team, scheduling presentations throughout the hospital, doing like two-part series. So there's different ways that this can be done. A really simple way to do this is to take the Conversation Project Starter Kit and host a group, similar to what you would do in the community, but within a healthcare setting, hand them out to staff, have a conversation, come back together 6 weeks, see what people have done and what they've learned and what that's been like. You have to be careful, of course. This is someone's workplace. You can't force the issue. You can't demand that they do it. But some organizations have started to build in wellness incentives for people to do this work, to declare a proxy and to have these conversations. The second principle, the connect principle, is really about finding cultural humility. And I really love that we are shifting away from the phrase cultural competence, because the notion that you're ever just going to be competent at understanding the cajillion different cultures that exist on this planet, ethnically, religiously, racially, gender, sexual orientation, socioeconomic, education-based, regionally, geographically, like these intersections that each of us carry in our own lives of different cultures, there's a practically infinite number of possibilities. So the idea that we could somehow become, quote, competent, I think is a little bit of folly, and I really love the transition in language to being culturally humble. So, excuse me for just a second. Sorry about that. These are two photos that I took on a family vacation in Ottawa. These are topiaries in celebration of the 150th anniversary of Canada. It's a couple of years ago, just for scale. The arrow is now pointing at people. So if you just want to get a sense of the scale here, those are people. And I'm not going to tell you this whole story, but this is a muskrat riding on the back of a tortoise. This is an ancient god in a canoe with lots of different animals. And this is a creation story from a First Nation community in Canada, which is in the United States what we would call Native American population. So it's a First Nation creation story. And it's a beautiful story. And this muskrat diving down, pulling up a clump of earth. And when I saw this and learned the story, it made me think of this work. Like, we have to be willing to hear people's creation stories. We have to be open to the idea that not everyone has the same creation story. Some people have no creation story. Like, we have to be humble about that. And then later on in our trip in Ottawa, I came across this, which is a 3D bronze map of the city. I love when I find these in cities. I always take pictures of them because I think they're amazing. This is a map that someone who is visually impaired can use to understand the architectural topography of a city. So this is the Parliament building, these are the locks, the canals that go along in the city of Ottawa. And I use this photo as a reminder to myself that we have to understand that people see in different ways. People have a different sense of origin, people see in different ways, and we have to be ready to be humble about that. We have to be open to hearing and understanding. So the CONNECT principle, I think, is really probably, I mean, they're all important. The CONNECT one is the one where we've probably scratched the surface the least, like where we really have the most work to do. One of my favorite examples of the CONNECT principle is the work that was done at the Henry Ford Health System. And they, excuse me, were involved in our early work and they started holding symposia between clergy and clinician dialogue partners. There's a reference for it here, and what was so incredible was that these two groups of clergy and usually physicians had so much to learn from each other. So the clergy would teach about the beliefs and the rituals of their religions, and the physicians would teach about the physiologic process of dying, and they have just forged this much stronger connection, because at the end of the day, when people are dying, it's often clergy and doctors that we're turning to, but they themselves were not speaking the same language, and often they were at loggerheads. I'm sure we've all experienced this if we work in healthcare, where, you know, a clergy member comes in and everyone's praying for a miracle, and the physicians are like, oh my gosh, what are we going to do? They think there's going to be a miracle, like, and it gets set up in an oppositional way. But through these partnerships and symposia, they've been able to move through some of that and tailor their advanced care planning outreach to underserved or underrepresented populations. Some other Connect examples: at Contra Costa in California, they did interpreter training, which is such a smart idea, because if you throw an interpreter into an end-of-life care conversation situation without them knowing what's coming, you're really counting on them to translate versus interpret, and you really want them to interpret. What's the difference? Interpretation is finding the meaning in what is being said and expressing that in the other language. Translation is that word for word. So with the interpreter training, they were helping their interpreters be ready to do this well. An example would be if you use the word focus, like we really want to focus on end-of-life care or comfort care, that word focus can have such a camera-specific meaning in some languages that it would actually be really confusing if the interpreter used the word focus versus pay close attention to, or narrow our, our options or something like that. At Boston Senior Home Care in Boston, they did amazing work with Chinese elders in housing communities. And there was so much that needed to be navigated in terms of working up the generational ladder of young people talking with elders about end-of-life care and not being disrespectful. Having to take the phrase, what matters to you, if you translated that directly into Cantonese, it would have zero useful meaning. So interpreting that phrase into something that would have meaning in Cantonese is another example of being culturally humble and finding our way into richer conversation with people. This resource from Stanford, Dr. Vijay Periacoil, I promise you, this is like a free graduate school education. I think these ethnogeriatric modules are some of the best things I've ever seen. It's just pure endorsement. I have no financial connection here. But what Dr. Periacoil and her team have done is they've taken these main 14 ethnic groups within the United States, and each one of these is a link, even in a PDF. It should still function as a link. And it takes you out to like a PDF module. I think, and it's not only specific to end-of-life care, but it is about the geriatric population of that particular ethnic group. Now, does it uniformly, monolithically apply to everyone? Of course not. Can it be a useful foundation? Absolutely, in two ways. I encourage using these modules for populations that you work with frequently, and I encourage you to use them with populations you work with infrequently. So for example, I work with some folks in Mississippi who do work related to organ donation. They have many, many African American patients. They have almost no Japanese, Korean, Pakistani, Vietnamese patients. So I say to them, if you're going to work with a family from an ethnicity that you're not familiar with, maybe go do some reading first. So I highly recommend these resources. They're really useful and written in such an accessible way. The third principle, engage, and again, please stop me anytime, please chat to all participants. The third principle is to engage, and that means moving from being reactive to being proactive. Why does it say Tar Wars on the screen? Why does it say tobacco cessation? because we are really good at proactively talking with people about their smoking. We are really good at proactively talking with people about their weight and their alcohol consumption and their blood pressure. Like, we have designed systems in healthcare that very reliably support having these conversations. I just went and met with a new primary care provider recently. She had my labs drawn. We had a really lovely, thorough conversation about my weight, my alcohol consumption, whether or not I smoke, my blood pressure. I promise you, I left that appointment. She had zero idea what matters most to me. I mean, zero. Like, I'm not even, you know, can't even remember if it came up that I have kids. Like, so we have designed systems that really hone us in on some pieces of data that I'm not suggesting they're not important, but they may have edged out some other things that are even equally as important. So how can we design systems that help us be proactive to talk with people about who they would want to have speak for them if they couldn't speak for themselves, and what matters most to them? And I know that's a very broad phrase, but it's broad on purpose because people come at that question from really different angles. You heard me say that what matters most to me is to intellectually and emotionally parent my children. Some people say what matters most to me is that you don't tuck the sheets in across my toes. It's one of my favorite answers we've ever heard. I want to hear music. I don't want my mean brother to be in the room. Like, there's such a spectrum of how people approach that question, and I really enjoy how broad it is. At Cure New England in Rhode Island, they created a formal Engage program called the Conversation Nurse. They had a new palliative care program, had explosive growth. About 70% of the referrals were for goals of care conversation. So they flexed a hospice liaison nurse into being the conversation nurse, and that became a specialized role. I'm not going to go into a lot of details because our dear colleague Kate Lally has written it up in the Journal of Hospice and Palliative Nursing, and that references here at the bottom. So it's a great program. It taught us a lot about what it means to do this reliably. And again, I'm not going to get into a lot of details here since it's written in the paper, but it helps them expand their reach. It helps them really reach more people. And as we're engaging, we've got to make sure that we're documenting what we hear when we ask, what matters most to you? I want to die at home. I want to see my sister before I go. I want to continue all treatment until it's clear that I can't communicate anymore. This is the kind of information that should be carried forward. Let me just make one more comment about Engage. Our colleagues at Beth Israel Deaconess in Boston, what they've done is that they have had the medical assistants in primary care take on the introduction of the healthcare proxy conversation, which is great. That's such a good example of having people operate at the top of their license. As they're rooming people, they're saying, hey, we've noticed that we don't have information that you've appointed a healthcare proxy. Is that something you've done and we don't have the paperwork, or can I talk with you about it? And certainly if the conversation gets more complex, the medical assistant can kick that up to the doctor for deeper conversation, but they've been able to dramatically increase their healthcare proxy completion rate in their primary care. This final principle that I'm going to talk about is steward, which we also call the allergy analogy, which means we need to steward, and we chose that word very purposefully. It's a deeper word than document. It means we have a moral obligation to take care of this information. If someone tells us who their healthcare proxy is, we have an obligation to steward that information. If someone tells us what matters most to them, we have a moral obligation to steward that information. My mom, who's in her mid-70s, full faculties, it drives her insane that she handed her healthcare proxy to her doctor 10 years ago and now nobody can find it. Like, what patients think our systems are doing, they highly overestimate how our systems work, and it's hard to break that news to people. So why do we use the allergy analogy? Because imagine, first of all, if we design systems that engaged as reliably as we do about allergies. But second of all, imagine if what we documented about allergies was, does this person have an allergy? Yes, or no. That's useless information. We need to know that it's penicillin. We need to know that it's latex. We need to know that it's aspirin. The way that most healthcare IT systems record this information is to say, healthcare proxy, YN, yes, no. Advanced directives, YN, yes, no. That's as useless as knowing that someone has an allergy, but you don't know what it is. So we need to know who the healthcare proxy is, and we need to know what matters most to people and if they have advanced directives. So that's why we use the allergy analogy, because we really want people to understand that we've got to go deeper in how we shepherd this information. The challenge, I'm not going to take you through every bit of this, but the challenge with stewarding is that often the patient establishes care when they're well, and all of this information, if it's discussed at all, happens with provider A. And then in the face of serious illness, organ failure, terminal illness, frailty, which is about how 90% of people die, they're then suddenly faced with provider B in the emergency department, in the ICU. And there's often no preceding relationship, and there's often no good way to connect up between these two entities. So we need to look at how we steward allergy information across boundaries and start to model better systems of stewarding healthcare proxy and what matters most information across boundaries. And this is the holy grail here. This is the part we have not yet fully figured out, but it's really at the heart of what Steward is. Quick example from Virginia Mason out in Seattle. Much like the AAA bail bondsman purposely chose the name AAA so that you'd find them first in the phone book. Virginia Mason created within their IT system an advanced directive note type so that it would fall up here at the top and it would be visible. So how can we make sure when we are caring for someone that this information is front of center? How can we leverage design? How can we leverage the alphabet? And then all of these principles come together to create respect. This is another photo from Ottawa. This is my daughter's hand a couple summers ago. And respect is the real outcome. We could exemplify and connect till the cows come home. We could engage in steward all day long, but if at the end of someone's life we don't access that information and strive to create a goal concordant care plan, it was all for naught. So we have to keep our eyes on the fact that this is all to get us towards respect. To close, you may have seen this already, but I always love to share it and I never tire of it, which is that back in the founding of the Conversation Project, one of our executives at IHI, Karen Boudreau, was sitting in a meeting and she started to panic. She was like, oh my gosh, I haven't talked with my adult children about this and her kids who were in their teens. And so she sat at the meeting and hand wrote this letter, which is typed over here. If you're faced with a decision that you're not ready for, it's okay. I'll try to let you know what I would want for various circumstances, but if you come to something we haven't anticipated, it's okay. And if you come to a decision point and what you decide results in my death, it's okay. You don't need to worry that you've caused my death. You haven't. I will die because of my illness or my body failing or whatever. You don't need to feel responsible. Forgiveness is not required. But if you feel bad, responsible, guilty, first of all, don't. And second of all, you're loved and forgiven. If you're faced with a snap decision, don't panic. Choose comfort, choose home, choose less intervention. Choose to be together at my side, holding my hand, singing, laughing, loving, celebrating, and carrying on. I will keep loving you and watching you and being proud of you. And I love this letter because it's just filled with heart and filled with love. But I would also argue that these three phrases, choose comfort, choose home, and choose less intervention, at the end of the day would give more guidance to Karen's medical team than would her thinking 20 years ago, would she ever have wanted a ventilator? So if we can express our values to our loved ones and they can bring those values to the medical team, I think that's where we stand the best chance of avoiding harm to dignity and avoiding goal discordant care. This is in the slides. I'm not going to go into great depth here because I'm mindful of the time, but this is just to let you know that if you were working with a healthcare organization and they were like, yeah, we're interested, but we don't know where to start, we encourage that people start with a 20-chart death review. Look at the last 20 patients that died and put your fingers on your own pulse of your organization. How often did you know who their healthcare proxy was? How often had there been some sort of values-based conversation, and did it seem like there was alignment? It's not perfect, it's far from perfect, but I think it's a good place to get the conversation started, and this slide is available to you. Okay, I'll stop there. Patty, apologies if I went too long.
No, this is excellent. Kelly, thank you so much. You've given us some really good examples. I love the stories that you started with your own family. But I also do love the realization that the procrastination sometimes happens. I can relate to that. It took me a little while to get this going with my own family. But you have given us a really good snippet of what is in that Conversation Ready white paper, which basically embodies years of work. So thank you so much. I'm going to ask people, we just have a few minutes. If you have questions for Kelly, go ahead and pop it in here. If we don't get to them today, we can get to them at post-call with the follow-up that we'll send out. So go ahead and pop that in there. I have a few slides to share at the end, but Kelly, let me ask you, it seems we asked folks at the beginning where they're coming from. Not everybody had a chance to answer because some are calling in, but we have a good mix of folks that are in the healthcare environment in hospitals, in community health centers, but we also have some folks that are community-based. And so do you have any advice for community-based folks or groups to approach their healthcare counterparts or to help get them interested in working together and building that will? I've heard on the road, we want our healthcare system to enact and start looking at these principles. How do you suggest bringing that to your healthcare component if you're a community member? What have you seen any healthcare people approaching their hospitals?
I guess I would just say start small. So if you are giving a community presentation and, a community doctor attends and seems really interested, maybe you could start to get some work going together on a very small scale. So our human tendency is to try to convince the laggards rather than starting where there's already energy in the system and starting small with built-in champions. If your own providers seem really tuned into this issue, you could start to say, gosh, I'm really hoping we might do this better at a systemic level. Is that something that you'd be interested in? Offering to help health systems do the exemplify piece. If you've got experience running conversation project starter kit workshops in your community, maybe you could start to offer them for the nursing home staff down the street or for the VNA. So I think starting with exemplify, we moved it to the front for a reason, because we really think this is where that work starts, and it might be a great way for a community setting to start to integrate with healthcare.
Great, that's fabulous advice. Thank you, Kelly. And I love that one example you gave with Erie. They did that. They started with a workshop. So start small, think big. You're getting some good feedback. So Jean said she'll use that letter and give it to her power of attorney. The letter always gets me when it's read. I think it's extremely powerful. I'm going to talk a little bit about a letter campaign that we have in just a sec. And getting some other thank yous and use for nursing students from Kathy Ahern-Gold. So thank you so much. I'm going to just wrap up with 2 slides. We're at the top of the hour, and just a huge thank you to Kelly and the team that's been behind this for sharing this. Just a quick reminder, the community calls, you can take a look at those, and hopefully those will fit into your schedule, so upcoming calls. We have the resources. So Kelly mentioned several resources. If you go to our the website, the Conversation Project website, and click on our Get Involved page, if you click on healthcare, the resources that Kelly mentioned, so the white paper, the Stanford ethnography resources that Kelly were talking about from VJ, those are on a link is on our website. So everything we have is here. We'll send anything else out through follow up with a call. So we want to make sure we have everything available for you guys. Just to quickly point out some articles and videos of interest that could be helpful as you think about this and think of ways to approach a team to start some of this up if you haven't. Kelly mentioned Kate Lally. Kate has been phenomenal doing work with Conversation Ready. She just came out with an article that details her experience with breast cancer and how that has made an impact on her as a provider. So the link here is having the conversation I encourage others to have. If you haven't yet seen that article, I encourage you to take a peek. We have a really phenomenal story from David Wood, who is a doctor from Beaumont Health, who's the Chief Medical Officer, shares his challenging experiences that he faced with his father's end of life. And it's an example of when wishes aren't respected and what really happens and what that has and what meaning that has on a family member. And then we have a video from Lachlan Farrow, Kelly mentioned Lachlan, which is an example of when wishes are respected and being conversation ready. It's a really beautiful video of Dolly Baker, who is a woman who is a patient of Lachlan's, and they share their story. So I encourage you to take a look at both of those. Lastly, and thank you for sticking with me, if you haven't seen already, we are hosting a letter writing campaign. So as Kelly shared the Karen Boudreau letter, in honor of NHGD, we started this campaign to help others share what they want and how they want to live and what really matters most to them. And so we've gotten a couple really phenomenal letters from some champions, some community champions like yourself, and just share some really fun and really touching end of care wishes with their family. And so just a couple quotes here. And for God's sake, have mercy and trim my chin and upper lip hairs. I love this. And then another champion mentioned, no heroics, listen to your mother. So I really encourage you guys to spread this. You can share some of this on social media. We're encouraging anyone to write a letter, and that's in our newsletter as well. Okay, with that, I know that's a lot of information. Thank you for sticking 2 minutes over. If you have 2 more minutes, when you exit the webinar, we'd love your feedback. We have basically 3 questions to just help get input on whether this was useful and if this helped you feel more prepared to be conversation ready. So please take a quick survey, and we hope to see you again in a month's time. And again, Kelly, thank you so much. Naomi, thank you. And thank you all for joining us today, and we will hope to see you in a month. And actually, if there's anyone else still on the call, just one last slide. I just want to say thanks and appreciation to our funder, the John A. Hartford Foundation, who funds this webinar series. So just wanted to give a shout out to them as well. Thank you so much. Have a great afternoon.